Now let's study about common pituitary tumors. Pituitary tumors can be microadenomas or macroadenomas. Microadenomas are those which are having diameter less than 10 mm. Macroadenomas are those which are having more than 10 mm diameter. These adenomas can be functional or non-functional. Some functional tumors produce more than one hormone, and most of the non-functional tumors produce intact gonadotropins or their glycoprotein subunits. Generally, these non-functional tumors are found incidentally during MRI or CT examination or during an autopsy. So they are also known as pituitary incidentalomas. Common pituitary tumors are macroadenoma with GH hypersecretion, microadenoma with ACTH hypersecretion, prolactin secreting adenoma that are also known as prolactinoma. Next is craniopharyngioma, metastatic tumors, and part of multiple endocrine neoplasia type 1, which involves parathyroid, pancreatic, and pituitary glands, that is 3P, parathyroid, pancreatic, and pituitary. And in pituitary, it mainly cause or usually cause prolactinoma. What are the clinical features that are associated with pituitary tumors? These are due to hypofunction by pressure on surrounding normal tissue, on surrounding normal pituitary tissue, so there can be hypopituitarism also. And due to involvement of neighboring structures, like if it involves the dura, then there will be headache. If it compresses the optic chiasma, nerve, or tract, there will be visual field defects, loss of acuity, and optic atrophy. If it involves cavernous sinus, as we can see that in cavernous sinus, 3, 4, and 6 nerve are related to that. So there will be 3, 4, and 6 nerve palsies, which will result in diplopia, strabismus, and facial numbness. If it also involves hypothalamus, then there will be obesity, disturbances of sleep, thirst, appetite, and temperature regulation. And as the ADH is secreted by hypothalamus, so there are chances of diabetes insipidus. Miscellaneous causes anosmia due to frontal lobe involvement. So there is deficiency of uh, patient can't smell the things. Anosmia is inability to smell. They can be headache, vomiting, papilledema, because due to these adenomas there may be raised intracranial tension, so there is papilledema. Next is due to secretion of these hormones. What the clinical features can be seen: if there is hypersecretion of growth hormone, then there is acromegaly or gigantism. And if there is prolactin hypersecretion, then is amenorrhea, galactorrhea, and impotence. So these are the three features that are seen in prolactinomas: amenorrhea, galactorrhea, and impotence. Due to hypersecretion of ACTH, there will be Cushing syndrome, and due to TSH, there will be hyperthyroidism. What are the investigations? So, to rule out the pituitary tumors or to diagnose the pituitary tumors, we will first do the plain radiograph of the pituitary fossa, which can show that there can be enlargement of sella turcica, or there may be erosion of clinoid processes, and they can be supracellular calcification, or they may be double floor of the sella. We can do CT scan also with contrast enhancement, which is more sensitive than MRI for bony erosions and presence of calcifications. So, if we want to diagnose the bony erosions and presence of calcification, CT scan with contrast enhancement is more sensitive than MRI. For soft tissue tumor, MRI is more sensitive than CT scan. Next we can do is visual field plotting to identify the site of lesion in optic nerve or optic tract. So we can identify where the lesion is present. If the lesion is present in optic chiasma, there will be bitemporal hemianopia. If the lesion is in optic nerve, there will be unilateral loss of acuity or scotoma. And if the lesion is in optic tract, there will be homonymous hemianopia. So other investigation that we can do is functional assessment of the gland, that is hormonal assays. We can do hormonal assays of prolactin, IGF-1, 24 hours urinary cortisol, FSH, LH and thyroid function test. So what will be the treatment? For prolactinomas, there is increased level of prolactin. So to decrease this increased prolactin level, we will use the dopamine agonist. As dopamine is inhibitory for prolactin, we will use bromocriptine and cabergoline, that are dopamine agonist. Or we can perform the surgery, and if we want to avoid the surgery, we can shrink the tumors by radiotherapy. We can give somatostatin analogs like andriodot and octreotide. These are considered first line medical therapy for growth hormone producing tumors अगर surgery possible ना हो तो. We can do transsphenoidal or transfrontal surgery, which will enable removal of the tumor. We can do radiotherapy, which will suppress the tumor growth and reduce its secretory capacity, and it is achieved by external radiotherapy, that is fractionated, or we can use gamma knife, or we can use modified linear accelerator. Gamma knife, that is stereotactic radiosurgery, involves precise delivery of large single high energy dose directly to the tumor under stereotactic surgery. So this is all for pituitary tumors. Main is prolactinoma. Prolactinoma, which will result in amenorrhea and galacturia and impotence. Thank you for watching. Like and subscribe.